Hello everyone, this is Seher. We are going to do the dental anatomy review today, a comprehensive review. So let's start with the first slide. Hello everyone, this is Seher from DENTABEST. So today we are going to review the dental anatomy subject. That's a very important subject of the exam. So we can see what are the contents that we are going to review: morphology, dentition, anatomical features, embrasures, grooves, tooth numbering system, permanent teeth anatomy, pulp morphology, and some section of occlusion like protrusive, mediotrusive, laterotrusive, rules of ideal occlusion, and Possel's envelope of motion. Now we can see different types of grooves like supplemental grooves. So we have a central groove that's running in the center, but from the central groove you can see different supplemental groove like thin grooves that arise from the central groove. And supplemental grooves, they are very common on the Maxi second premolar that gives it a wrinkled or a crenulated appearance. Now, embrasures are triangular shape between the proximal surface of adjacent teeth, which diverges in 4 directions from the contact area. So you have buccal embrasure, lingual embrasure, occlusal incisor, cervical gingival. As we know, embrasures are going to form the spillways or the self-cleansing areas. Interproximal space that is covered with gingival papilla or filled with gingival papilla in the healthy condition. And you can also remember where is the largest occlusal embrasure, largest incisal embrasure. Largest occlusal embrasure like between the maxi canine first premolar, largest incisal embrasure is between the maxillatral canine, and the smallest incisal embrasure is between mandibular central. In general, the lingual embrasure are larger than the buccal embrasures. That's why when you insert the wedge, usually inserted from the lingual side. Now the height of contact table is also very important. You always have questions on them. So you have the central incisor, the lateral incisor, canine. For the maxillary, the height of contact. So you can see that height of contact is on the cervical 1/3 of the facial height of contact, and cervical 1/3 for all the teeth. While lingual height of contact for anteriors will be in the cervical 1/3 for the cingulum area of the anteriors, and the lingual height of contour for posteriors of the maxi anterior will be in the middle 1/3. Now you may have to also memorize where the mesial and distal height of contact. Mesial and distal height of contact, they have given you a good mnemonic here. If you can see I, J, J, M, 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 right? So that will help you in memorizing the mesial and distal contact for all the teeth. Also, you should know number of lobes, number of canals, number of cusp. Although the dimensions, what is the dimension, 13 mm, 10.5 mm, how much is the crown length, how much is the root length, this is not that important. If you want, you can just skip it. You can see more points about the height of contact of maxillary on the left side. Now we can see the maxillary permanent teeth, starting with the maxillary central incisor. So we know the maxi central incisor is one of the most prominent tooth we have in the arch, having greatest mesial CHA contour. And this is the second longest crown because mandibular canine is the first longest crown, second will be maxillary central incisor, and third will be the maxillary canine. It is the tooth which is widest mesiodistally. 3 mamelons, right? So mamelons, they represent each lobe. So there are 3 lobes makes the facial surface of anterior. So there will be 3 mamelons. Mamelons are found on the newly erupted permanent teeth, but as we age with the attrition, these mamelons should disappear. If you still have mamelons, that's a sign of malocclusion. So the disto-incisal corner is rounded, as you can see, and the mesio-incisal corner is sharper. Cingulum is distal and it's having least likely to have a divided root canal. Maxillary incisor, you can just rotate and extract it, having the roundest root form. Axial inclination towards the facial. And this tooth sits almost vertically, mesiodistal in the alveolar bone. And if I ask you which tooth sit almost vertically buccolingual in the alveolar bone, your answer is maxillary first premolar. Now when we see the lateral incisor, so lateral incisor is the most common congenitally missing tooth? No. Actually, the third molar, maxillary third molar, is the number 1 most common congenitally missing tooth. Number 2 will be mandibular third molar, and number 3 is maxillary lateral incisor, and number 4 will be the mandibular second premolar. But just like third molar, lateral incisor also have very variable tooth form, like dense invaginators, dense evaginators, pack-shaped lateral, dense indenti, that's dense invaginators, they're common on the lateral incisor. Also, among all the incisor, lateral incisor lingual anatomy is very pronounced. It has a deep lingual fossa, deep lingual grooves that has highest chances of caries. So lateral incisor, one of the most common tooth to have the lingual pit restoration. Also, lateral incisor has a palatoradicular groove that make scaling very difficult for this tooth. Dense evaginators on the lateral incisor can be like a talus cusp appearance. The root is curving towards the distal side. Okay, so now let us talk about the Maxi second premolar. So as compared to Maxi first premolar, it is shorter and smaller. And distal cusp ridge is longer than the mesial cusp ridge. It has a buccal ridge but not as prominent as first premolar. The most important point about Maxi second premolar is having the supplementary groove. Supplemental groove will give it a wrinkled or crenulated appearance. That's the most important thing. It has a single root. It has two cusps, buccal and palatal, which are almost equal in size. Now the maxillary first molar, we know it's one of the largest permanent tooth. It's the first maxillary tooth to erupt. Widest tooth buccolingually. So if they ask you which is the widest tooth buccolingually, overall is the first molar maxillary. But widest tooth buccolingually within the anteriors is going to be canine. Only tooth that is broader lingually than buccally, pronounced distal concavity at the CJ with a central pit. Has a distal lingual groove with a pit. Mesiobuccal, mesiolingual, so it has 5 cusps. Mesiolingual, largest, then mesiobuccal, then distobuccal, distolingual, and smallest will be cusp of caraboli. Now the primary and the secondary cusp triangles are formed in this tooth, where primary cusp triangle is formed by mesiolingual, mesiobuccal and the distobuccal cusp, and the secondary cusp triangle is formed by the distolingual cusp. You can see the size sequence too. The most prominent oblique ridge on the maxillary molars is on the maxillary first molar. The transverse group of the oblique ridge connect the central and the distal fossa. 3 roots, mesiobuccal, distobuccal and palatal, where distobuccal is shortest and palatal is the longest root. And we know the palatal root can be very close to the maxillary sinus. You have to be careful while doing extraction because you can easily make opening into the sinus. So mesiobuccal and distobuccal root, they are like plier handle, divergent, and palatal root is like a banana shape. Now all the teeth, we should also know the occlusal principles they are following, right? So every tooth occlude with 2 other teeth in the opposing arch. Every maxillary tooth contact 2 other mandibular teeth, the one tooth that is antagonist to it of the same name, and the other tooth that is distal to it. For a mandibular teeth, also they contact 2 other maxillary teeth in the opposing arch, the one tooth that is antagonist to it and the other tooth which is mesial to it. There are 2 exceptions to this rule. Mandibular central incisor that only contact 1 tooth maxillary central incisor, and second is your maxillary third molar which only contact mandibular third molar. Other than that, all the teeth they will contact 2 other teeth in the opposing arch. Now we talk about the mandibular permanent teeth. Now the mandibular permanent teeth, as we know, it is the smallest tooth, narrowest mesiodistal diameter it has, very symmetrical tooth. Like if you divide the tooth into 2 halves, both the right half and left half are mirror images of each other. Both the mesioincisal and distoincisal corners are equally sharp. Both the ridges are equal. It is the first succedaneous tooth to erupt. Succedaneous teeth are those permanent teeth that replace their primary. If I say last succedaneous tooth to erupt will be maxillary canine. All the permanent mandibular teeth, they have a lingual inclination. So their incisal edge of mandibular incisors will also be lingual to the long axis. Cingulum is central here. Mesial and distal concavities, hourglass shape on the root. Only anterior tooth to occlude with one other tooth. Now mandibular lateral incisor. It is the second smallest tooth, not as symmetrical, and the very important feature of lateral incisor is that the incisal edge is distolingual twisted. So distolingual twist on the incisal edge is a very important feature of the lateral incisor. Longest root of all incisors, and the cingulum is slightly distal here. It also has mesial and distal root concavity, hourglass shape. Now we can see the mandibular second premolar. We know it's one of the most common congenitally missing premolar we have. And mandibular second premolar, it can exist in three forms: Y pattern, H pattern, and the U pattern. Y pattern, which is the most common pattern, it will have three cusps, while H pattern has a straight groove. U pattern, you can see it's a twisted groove, which are two cusp pattern. So mandibular second premolar Y pattern can be made up of 5 lobes, 3 buccal and 2 lingual. And we know mandibular second premolar has an apex closest to the mental foramen. Now if we see the mandibular first molar is have the widest tooth. Okay, one more thing about the second premolar. So all the premolars we know they have a single root, except your Maxi first premolar, which is having the 2 roots. Now Maxi first molar is one of the widest tooth mesiodistally. It is one of the first permanent tooth to erupt and most often restored or extracted. So most common to have RCT done too. When you see it from the buccal side, you can see all the 5 cusps. And buccal cusp are shorter and blunter than the lingual cusp. Now if you see the size sequence here, you have the mesiobuccal cusp, that's largest, then mesiolingual, that's tallest, then distobuccal, then distolingual, and the distal cusp is going to be the smallest cusp. So if you see it occlusally, it will give you in as like a plus arrow pattern. You can see in the picture, it's like a plus arrow pattern. So the distal cusp will be on the buccal side. So it will have a buccal groove that will divide buccal surface into mesiobuccal distobuccal cusp, a lingual groove that will divide the lingual surface into mesiolingual distolingual, and there's a distobuccal groove that will divide into distobuccal cusp and the distal cusp. It's like a plus arrow pattern with a twisted central groove. It has 2 transverse ridges, 3 fossa with pit, 2 buccal groove, mesial and distobuccal, and a short lingual groove. Root is longer and wider. So we know on the first molar we have 2 roots, mesial and distal. It's a mesial root which is longer and wider than the distal root. Also the mandibular first molar, it has a pentagonal outline that give it a home plate. It's called as a home plate occlusal pattern. Now we can see here. Okay. Now in the occlusal section, we see this is called as a Possel's envelope motion, right? So Possel's envelope motion, they're actually border movements of the mandible. The extreme movements of the mandible are recording the Possel's envelope motion. For example, when you give denture to the patient, you want to see that how far the patient can go with your denture. How extreme protrusion, extreme opening, extreme right, extreme left lateral, how much he can do. So these are the border movements of the mandible. They are not the normal chewing movements. So this is the first curve. That's a sagittal plane. Second curve, this is diamond shaped tracing or Gothic arch tracing. It's in horizontal plane. And the third one, which is the teardrop shaped tracing. This is the frontal plane. So sagittal plane, the first thing you see, this is centric occlusion. Ask the patient to bite. That's the most superior position. Then you ask the patient to swallow, come in retruded contact position or centric relation. It's around 1 to 2 mm posterior to the centric occlusion. Now ask the patient to start opening the mouth. So initial 15 to 20 mm of opening, there will be only rotation. And the further opening until he reached to the point of maximum opening will be the translation. Now once he has opened the mouth maximum, ask him to close his mouth again. That will be centric occlusion. Then ask him to rest position. Bite again. And then start protruding his mandible. Come to edge first and then come to maximum protruded position. Once in maximum protruded position, ask him to open his mouth widely as much as possible. So that's how you are tracing the curve. Now this curve in the center of the envelope of motion, this is the normal chewing cycle. It does not come in the border movement of the mandible. So we know the intercuspal position or centric occlusion is entirely tooth guided position. Centric relation is ligament guided and rest position is postural rest position is muscle guided position that we have. The second picture is in the horizontal plane or the Gothic arch tracing. You can see. So you have the retruded contact position here, that is RC. Then there is a centric occlusion. So ask the patient to come in the bite, then to swallow, And both from centric bite and centric relation, you ask the patient to come to maximum right and maximum left. But you have to ask him to come to edge and then go to maximum right and maximum left. And both from maximum right and maximum left, ask him to protrude his mandible to the maximum. That's how you do the second arch tracing. Third is a frontal or coronal plate tracing. It's like a teardrop shaped tracing. You can see it is starting with the centric occlusion, maximum right, maximum left, and both from maximum right and maximum left, you're asking the patient to come to maximum opening. So you're not asking the patient to go into centric relation from here. Now we know about the guiding cusp and the supporting cusp. So guiding cusp are the balancing cusp, or they are the non-working cusp, or the non-supporting cusp, or the non-centric, or the shearing cusp. So there are many names of the guiding cusp. So bull, buccal of upper, and lingual of lower bull are the guiding cusp. The supporting cusp are the working cusp, centric holding cusp, or the stamp cusp. Like a mandibular buccal and maxillary lingual are the working cusp or the supporting cusp. Now what are centric stops? Centric stops are the areas of contact that a supporting cusp makes with the opposing teeth, like mesiolingual cusp for maxillary molar with the central fossa. Now in the central occlusion, the opposing contact may be expected at the buccal slope of the lingual cusp of the maxillary posterior teeth, and in crossbite, definitely this situation will get reversed. Now you can have anterior crossbite, posterior crossbite. This we already discussed in orthodontics. Now supporting cusp versus guiding cusp. So supporting cusp, they are the working cusp. They make contact with the fossa or the marginal ridge. And guiding cusp related to interproximal areas, embrasures, or the developmental groove. Now maxillofacial cusp and mandibular lingual cusp, they require sufficient occlusal length and the horizontal overbite, overjet, or overbite. Okay, so on this slide we are discussing the excursive movement. Right, so excursive movement, we can see some of the points here. So lateral trusive movement that are on the working side, medial trusive movement that are on the non-working side. So lateral trusive movement or excursive movements, lateral trusive side. The teeth that ideally provide the predominant guidance for the excursive movement is through the canine. In lateral excursion, the mandibular canine cusp tip passes mesial to the maxillary canine cusp tip. The lingual of mandibular first molar must be restored to accommodate the working movement. From right lateral to centric, distal buccal cusp of the mandibular second molar moves to the buccal groove of the right maxillary second molar. During a working movement, the facial cusp of ridge of the maxillary first premolar on the working side oppose the distal cusp ridge of the mandibular first premolar and the mesial cusp ridge of the mandibular second premolar. In the right lateral movement, the lingual cusp of the right maxillary second premolar passes through the embrasure between the right mandibular second premolar and the first molar. In a right lateral excursive movement, the mesiolingual cusp of the permanent right maxillary first molar passes between the lingual cusp of the mandibular first molar. This mesiolingual cusp passes through the lingual groove of the mandibular first molar. Now we can see here, in right working movement, the mesiolingual cusp of left maxillary first molar moves to the sulcus between the distal buccal and the distal cusp of the mandibular first molar. So these are some of the rules of the lateral trusive movements that you can go through it. So in lateral movement, there should be no contact on the non-working side. So that is very important. Just remember, the working side is a side that work. It is making the contact. So this is about the lateral trusive movements that we have. So Bennett movement, we are also going to discuss it again on the next slide. It's a bodily shift of the mandible or the working side condyle towards the working side. And this Bennett movement occurs during the earlier stages of the lateral movement, which will influence the mesiodistal positioning of the cusp on all the molars. This is the influence of the Bennett movement potentially on the working side teeth in the lateral movements. So when an exaggerated Bennett component is present in the lateral jaw movement, it has its greatest potential for interference with the mesiodistal positioning of the cusp tip and mostly influence the lingual concavity of the maxillary anterior teeth and the cusp height and the groove direction of the posterior teeth. Okay, So on now this slide, you can see the mediotrusive and the protrusive contacts too, right? So what will be the cusp relationship, occlusal relationship in the mediotrusive contact? Like on the mandibular first molar, the distofacial groove serves as an escape way for the mesolingual cusp of the Maxi first molar during non-working mandibular movement. The non-working condyle move downward, forward. The non-working pathway of the Maxi cusp on the mandibular posterior teeth is always towards the distofacial. In a patient with the left canine protection, the mesolingual surface of the right Maxi first molar contacts the distobuccal surface of the right mandibular first molar during a left lateral excursion. And this contact is a non-working side interference. On the non-working side in ideal occlusion, the interfering contact on the posterior teeth will be located on the inner incline of the maxillary first molar and the mandibular supporting cusp. So you can go through these rules as well. And these are some of the rules for the protrusive. The most likely mandibular movement, condylar movement, a bilaterally symmetrical condylar movement. Lateral pterygoid mainly helps in the protrusion, where the condyle move forward and carries a disc along with it, and disc to be tilted in supro-inferior fashion on the condyle. The mandibular incisor, they make contact with Maxi incisors in the protrusive movement, lateral protrusive movement, and contacting surfaces around the lingual of the maxillary incisal edge of the mandibular. In a protrusive contacting movement, the maxilolateral contact the mandibular lateral and canines. In a protrusive movement, the facial cusp tip of the mandibular second premolar has the potential to contact distofacial cuspal incline of the maxillary first premolar. So all these rules, also you can go through it. The protrusive pathway of the mandibular cusp on the maxi posterior teeth is towards the mesial. Now you can also see the next slide, that is on the Bennett movement. So Bennett movement is, for example, you have the right side working movement and the left side non-working movement. So right side is your working side, left side is your non-working side. So when your mandible is moving towards the right. So left side, although it is called as a non-working side, and left condyle is called as non-working condyle, but it is doing all the work. It is rotating, it is translating, going downward and forward along the slope of articular eminence. It is the left side that is shifting the mandible towards the right side. Non-working side is also called as the mediotrusive side towards the tongue. Now the right side, which is a working side, and the right condyle, that is the working side condyle, it will do the rotation and do a slight bodily movement, a slight bodily shift towards the lateral side, towards the cheek side. And that slight bodily shift of the working side condyle towards the working side is called as the Bennett shift. So that is an important point about the Bennett shift and the Bennett movement. That's the same words. Now your Bennett angle is another term that we have. So Bennett angle is formed on the non-working side condyle. Between the long axis of rotation on non-working side condyle and the terminal hinge axis, the Bennett angle is being formed. So when you have different types of condylar movements like protrusive movement, right working, left working, in protrusive movement, both right and left condyle will rotate and they will translate forward anteriorly together along the articular eminence, downward and forward along the slope of articular eminence. Now right working movement, it's your left condyle that is doing all the work. Left condyle rotate, translate anteriorly, downward forward along the articular eminence and go medially towards the right. But in left working movement, the right condyle is doing all the work. But the working condyle in the left working movement, that's the left condyle, will just rotate and do a slight bodily translation or shift towards the working side, towards the left side. And that is called as the Bennett shift. Now, one more thing that is important here related to your Bennett shift and the Bennett movement is what is the significance of the Bennett movement. Hi my dear student who are preparing for IMD ADAT Part 2 exam. Thanks so much for watching this review video of the subject. If you really liked it, please buy the full version by clicking on the link given in the description. With the purchase of every video, you will be getting free live assessment and evaluations on the subject as well. Also, don't forget to subscribe to the DENTABEST channel now to get the latest updates on the smart videos. If you have any questions, please comment me in the box below. I, Dr. Seher from DENTABEST, wishes you all the best for exam and thanks again for watching.